joining in this webinar on adult health issues in Fragile X syndrome with Dr. Jonathan Cohen. The webinar is for family members, carers, and disability support providers who have adults with Fragile X syndrome in their care. My name's Graham Hook. My son James has Fragile X syndrome, and I've been involved with the Fragile X Association in Australia for about 30 years. Before we begin proceedings, I would like to acknowledge the traditional owners of this land and all lands on which we are meeting today, and pay my respect to elders past, present, and emerging. Dr. Jonathan Cohen is the Medical Director of the Fragile X Alliance Clinic in Melbourne and Genetic Clinics Australia, and he is a Fragile X parent. Dr. Cohen is familiar with many of us, having presented at workshops around the country and having seen many Fragile X families over the past 25 years or so. We appreciate his time and expertise. I'll now hand over to Jonathan to present the video.
Well, thanks very much for those kind words, Graham, and thank you to the Fragile X Association of Australia for setting up tonight. These are four brothers who live together quite successfully in a regional town in Victoria. They've grown up together, they've always lived together, and it's one of a really good example of how well group homes can work. These guys look after their house, they keep it clean, they keep the garden incredibly tidy, they cook, and they look after each other. Like all brothers do, they niggle each other every now and then, but they're done really well, and they're well known and well liked in the local community. One of them still working part-time, I think on a volunteer basis, and they've done different things through their lives. These are two sisters who each married two brothers, and they each had a son with Fragile X. One had a daughter with Fragile X, who herself had a daughter with Fragile X, and they've had a really good quality of life throughout their time. I want to emphasize that Fragile X syndrome is a neurodevelopmental disorder as opposed to a behavioural condition. So certainly people have behaviours that we all know in Fragile X syndrome. But I want to emphasize that these are result of neurologically different wiring. As a summary, for those of you who would probably already know this, and for those of you who don't, the expansion of the long arm of the Fragile X gene, you can see down the bottom right, was seen under the microscope. In fact, when you go down and drill down a bit closer, that expansion is in fact a long double helix of molecules that have expanded more than 200 repeat times. And once the DNA expands to that length, the gene switches off production of the protein, which is necessary for normal neurological development. That results in the Fragile X syndrome. The gene can expand a little bit, and if it's only between 50 and 230 repeats, then we use the term carrier or premutation. It's when it's greater than 200, 230 repeats that the gene switches off and results in the Fragile X syndrome. So tonight we're talking about the full mutation, not the premutation. So the premutation leads to conditions such as Fragile X tremor ataxia syndrome, Fragile X premature ovarian insufficiency, and the Fragile X associated neuropsychiatric disorders, which the Europeans call Fragile X premutation associated conditions, preferring the word conditions to disorders. We won't be talking about the premutation, that's in the boxes on your left. Tonight we're talking about the full mutation. The full mutation presents with three things: developmental delays, emotional and behavioural disorders, and also physical features, which are not always seen. So the developmental delay that we see is global. So it's milestones are delayed, there's delayed development and persistent difficulties with fine and gross motor coordination, and also intellectual difficulties, learning difficulties. The problems that people present with are largely emotional and behavioural, and these will be familiar to all of the families watching tonight: the anxiety, arousal, attention deficit hyperactivity disorder with or without hyperactivity, and autism spectrum disorders. The physical features, which are not always seen, don't have the features that we see. They don't necessarily mean anything other than the loose connective tissue, which can lead to problems with flat feet and heart valves, sometimes reflux, gastroesophageal reflux, and we pay attention to those as they become apparent. So the job of medical people in seeing people with Fragile X is to firstly exclude medical issues. Someone comes in with a problem, then it's important for them to, for the doctor to make sure there isn't a medical problem, or if there is, to be able to treat it. Their second job is to advise how to prevent medical problems from occurring in the future. The medical conditions that we commonly see in Fragile X are listed here. We sometimes see these mitral valve prolapses and difficulties with the aorta, the main artery coming out of the heart, getting enlarged, and that's common with a lot of the connective tissue disorders. More commonly, we certainly see crowded teeth and dental problems, dry skin, recurrent ear infections, and all of these medical issues that sometimes get missed. And the importance of seeing someone for regular medical care is to inquire about these, and then you can do something about it. So something like constipation, which can cause tummy pain and then altered behaviour, is very readily resolved with a high fibre diet and sometimes some laxative medications. Reflux esophagitis can be very well managed with anti-reflux medications. I've put a lot of medications here for the conditions that we treat because they're largely mental health conditions, things like anxiety, mood disorders, epilepsy managed with anti-seizure medications, mood stabilizers, people that have continence issues. Again, there's a range of strategies. What I want to emphasize here is that medications are half the story. So it's important with a lot of the behavioral issues that we see to firstly diagnose the mental health disorder and treat that, but also to put in behavioural management strategies. Both are needed. Behaviour management strategies don't work well by themselves. They often need the help of medications, not always, but often, and vice versa. Medications don't work brilliantly by themselves. They can be very helpful, but they work best when used in conjunction with behaviour management strategies. There is a separate webinar that is up on the Fragile X Association of Australia website dealing with medications. I wanted to talk a little bit about restrictive practices versus medical need. This is a common question that we get from some of the families, some of the carers, that when we prescribe a medication for someone with Fragile X, we're asked, isn't this a restrictive practice? And the basis of this goes back to the days when people were given medications in aged care to keep them quiet and stop annoying the nurses. So there was a big kickback against this, and they call that restrictive practice. With Fragile X, it's very different. These are people who have got significant difficulties with hyperarousal, anxiety, ADHD, obsessive thoughts and compulsive actions, obsessive compulsive disorders, and they need medications for a medical need. So it's not, the term is not restrictive practice, it's medical need. Best example of that is epilepsy. Someone has a seizure, gets treated with medication. It's not a restrictive practice. And the same thing with a neurological cause of anxiety and Fragile X syndrome needs to be managed with the appropriate medication. So we will hopefully talk about this in a Q&A session at a later time. So here's a guy that was misdiagnosed with schizophrenia because he spoke strangely and he acted strangely, and he was actually institutionalized years ago in a psychiatric hospital in Melbourne before someone realized that, hey, he's actually got intellectual disability. And then he got a blood test and was found to have Fragile X syndrome. So he was diagnosed at about the age of 50 When he came to us, we did a full medical check on him. We checked his hearing and found that it was actually very low. So that line below the 20 decibel line shows that he's really very low in hearing and actually would benefit by a hearing aid. So it's important, I want to emphasize the importance of checking simple things like hearing and vision regularly in adults with Fragile X syndrome. They often just get missed. We put together care plans for people with disabilities or complex medical needs, and Fragile X is no exception. Here's an example of something that we would routinely put together and give to a family to follow through and check on following diagnosis. This is not just for children. This doesn't stop. This goes all the way through adulthood, and it's important to regularly check, get your hearing checked and get vision checked for anybody, let alone someone with Fragile X. Flat feet are common, so a lot will benefit by having an orthotic put into their feet, into their footwear. They'll need to see a podiatrist for that. We need to look at and think about, are there other things going on? So depression is not common in people with a full mutation, Fragile X syndrome. But we do see, keep mentioning, we do see a lot of anxiety. So panic disorder, generalized anxiety disorder, and we would manage the appropriate medication. It's often important for somebody to be assessed if they haven't been previously by a psychologist. And I can't underline enough the need for speech and language therapy speech and language therapist for someone with Fragile X syndrome, because it helps them communicate. This is especially important in a situation where someone is not able to explain readily what they need, or if they get upset easily. They need to be helped to learn how to communicate their needs to the people around them. And this is, I was saying before about behaviour management. If someone is put in a situation they don't like, they're not going to be able to say, I don't like this, I would like to do it in a different way. They're just going to erupt. And so teaching them to communicate how to say, I don't like this, can we do something else, is a really important tool for everybody. Similarly, an occupational therapist is so important for doing a sensory workup to look at what the person's sensory needs are and sensory dislikes are. This is important for workplace, for day programs, and for wherever they live. I put paediatrician there, of course, that doesn't apply to adults, but we sometimes need to consider a neurological or psychiatry opinion for someone if there's something else going on that's not typical for Fragile X syndrome. GPs are the linchpin for preventive care, and there's a routine program that GPs do in residential units and in institutions for people. It's a regular annual health check developed by Nick Lennox here in Australia. And it's something that really every GP is familiar with. People with intellectual disability often don't live a full life because things get missed and picked up a little bit too late. They deserve and need to be given the same preventive checkups that everybody else has. And obvious as that is to many of us, this is something that sadly gets missed. You know, we get too busy worrying about the behavioural problems or the accommodation issues, and we forget to get these things done. I don't think anybody watching this tonight would be missing these, but this is a general thing that we see. We've had a number of cases of people presenting very late, and things could have been just picked up a little bit earlier. The NDIS, of course, has been an absolute boon. It's important to know what terminology to use when putting in the applications. The underlying aim of the NDIS is to improve an individual's capabilities. It's to make sure that they are able to maximise their abilities or develop them to maximise the ability to be independent. So some of the terminology that is used in the NDIS applications are people look for mobility skills. And of course, a lot of people with Fragile X, especially the males, will have difficulty with fine and gross motor coordination. And so it's important to write that they require assistance from other people for guidance and prompting. for transport, for example. Communication is a similar situation. People require assistance from other people. People with Fragile X require assistance from others to help with instructions and how to communicate their needs. And someone can be put on to work on their communications, and in this case would be a speech and language therapist. And we're aware of quite a few people that are deriving great benefit from learning how to interact in different situations, how to resolve conflict, how to organise, to ask someone to go out for a walk. So simple things like that can make huge differences to a person's productivity, self-esteem. And that's the target of the NDIS. Social communication issues, which of course are very common with both males and females, adults with Fragile X syndrome, can be taught. There are ways to teach people wording to use, key sentences, introductions, how to fill a gap in a conversation, when not to speak. All of these things can be enhanced at the very least, and certainly a lot of people will benefit by ongoing input at any age. And not necessarily just with Fragile X, but certainly with Fragile X. Learning, we see quite a few people that start to learn to read in their 30s, or they're not ready when they're younger, and school environment may not have been great for them, but they get into their 20s and 30s and they're ready to absorb, they're ready to learn. But unfortunately, there aren't schools or institutions in general for a lot of adults. There are TAFEs, but people sometimes underestimate what somebody can do. And, you know, they've always struggled, so they've given up by the time they get to the age of 30 or 40 and think, oh, they'll be okay. But it's really interesting to see what people can learn to do in different environments. And maybe we can talk about some of those examples from your own experiences later on. Self-care, some people are great, some people need a lot of help with self-care. And these are all of the things that can be provided through the NDIS. Of course, financial management is a big one. I'll talk about a few scenarios now, which I hope we can speak about in the Q&A session. Workplace environment. It's really helpful to find an employment support person. And again, the NDIS has spawned quite a few organisations with some wonderful people, mostly, who will work very hard in communicating with the workplace what the person's needs are with Fragile X. It may mean modifying the hours or the sort of work that they do. But in general, a lot of people with Fragile X who work, they make great workers. They don't slack off. They don't spend their time on the phone or sneaking off to have a coffee. They'll do they're very concrete. They'll do what they're asked to do. And they'll even try to turn up if they're not well. Not all, but a lot. And it's important, if someone does want to work or is interested in doing something, that they get that external support. It's often difficult if you're a family member to negotiate. So a support person will have all of those skills. Routines need to be established. We use visual timetables, and sometimes rehearsal can be very helpful. I'll mention this later, but rehearsing with videoing somebody doing a task is a great way to show somebody with Fragile X what to do, because they'll then naturally just copy that task. Visual learning is a key way for somebody with Fragile X. So examples of some of the industries that we see that the guys work in are things like hospitality, horticulture, cleaning, and even in supported employment. Of course, a lot of females will do other things as well. We see some working in childcare, some actually working is in a bank situation or as a bookkeeper. Interestingly, because maths is often not a great skill, but bookkeeping is very black and white. It's something on one side of the column has to equal something on the other side. So the females seem to be able to function a lot higher, at a lot higher level, although it's rare that they would be getting into a high-end university course, although that certainly does happen. Going back to education training, this sometimes happens at a later age. You know, historically, everybody finishes school and then you go into training. Fragile X, sometimes they're not ready for another 5 or 10 years. Sometimes they are, but it's important to, it's horses for courses. It's important to look at the person and see what they're interested in, what they're able to do. And not a lot of the time, but sometimes we see people that are clearly able to do a lot more than they're judged to be able to do. And for example, driving. Some people will learn to drive, some people won't, but it gives an independence. It gives them independence, or travel training as well. So all of these things should be attempted to be taught, and slowly, carefully, but following a very concrete procedure. So following routines, do something this way and then you follow this. So if it's written down and with pictures and visual timetables, a lot of people will be able, surprisingly to some, will be able to follow an educational process. And again, rehearsal can be videoed just on a mobile phone. It's a great way to learn a skill. Moving on to accommodation options, there are quite a few, and it's probably not very diplomatic of me to say this, but I have a bit of a thing about community residential units, because I think a lot of the adults that we see who come in are struggling in the CRUs, the community residential units, and they're struggling because they're living in an enclosed place with other people with challenging behaviours. And, you know, it's very difficult when someone comes in and the staff person says, oh, you know, they threw the soup against the wall. You know, why are they doing that? And I'll say, well, what soup was it? It was mushroom soup. Do they like mushroom soup? No, but that's what they get for dinner. So, you know, their way of saying, I don't like mushroom soup, is to throw the soup away. And I'm often surprised that a lot of, most people who work in the CRUs are very good, but there are a lot of people that don't get who it is they're working with. They challenge people sometimes with a loud voice, and then get surprised when the person reacts back. So I think there is a lot of space and a lot of need for a lot of the carers who work in these places, and it's a hard job to be given some training, and that's where the challenge is with a lot of the people that we see, is the interface between where they would like to live, how they would like to live, and where they're put to live. And I sometimes wonder if we're doing the right thing, putting a lot of the the people with Fragile X through school, when really they should be living out in the country. And certainly the people that we see who are in rural areas and in regional towns seem to do a lot better than people living in the city, where it's noisy and crowded and often very challenging environment. So people move from the family home. Some live for quite a long time in the family home, and then there are options which ideal for Fragile X would be cluster housing. Cluster housing is the aged care model where each person gets their own unit, which is clustered around a central eating and recreational area, so they can choose to come in and interact with other people, or they can be in a nice quiet place by themselves. And the most successful CRUs that we've seen is where there's been a unit like a granny flat attached, and the person can withdraw into their space when they need to. And that reduces the sensory overload, and I think that's what is happening there. Speaking a little bit about abuse, it's a very difficult and awkward and sad topic, and we know that from the Victorian figures, and they're mirrored by the other states, that there's been a fair amount of all sorts of abuse, including physical and sexual abuse, to people who are prone in aged care and in the disability sector. And I don't have any quick fixes for these at all, other than there needs to be zero tolerance and for this to be called out. Now, we've had a few situations where someone's been living in a CRU or in a shared house, and everything's been fine, and then all of a sudden the behaviour changes. So they've been absolutely fine. They've been on the same medications, the same work, same day program, same people. Nothing has changed. And then all of a sudden their behaviour changes. Now, when they come in, I go very quiet, because usually people come in, they say, oh, their behaviour's escalated and they need more medication. So here I am, the person who prescribes, and I'm saying, well, what's changed? What's different? Silence, nothing. Does anybody new come in? There's a nod. So there's been a new staff member who'd started a month before, and then the behaviour had changed. Or a new client had come in, a new co-resident had come in, and something had changed. And all too often, months later, we find out that somebody had been doing something they shouldn't have been doing in that place. It doesn't happen a lot, but it happens enough for me to raise the issue when there's a sudden change in behaviour, to ask that question. Has anything changed? Is there anything going on? Are they reacting strongly to one person? Now, it can be that that person is simply loud, that they've got a loud voice, and people with Fragile X don't like people with loud voices or strong perfume, or being asked to do something that they don't want to do, or that's something that's too hard. But it's important to ask the question. And I think by asking the question, people, staff and other people at the institutions, these many institutions, the residential units, will be on their guard a little bit. So I think perhaps we can speak about that later. But the other form of abuse that is now termed is nutritional abuse. And that doesn't mean someone who's being starved, because that doesn't happen very often these days. But it can be someone who's being fed too much and allowed to become obese. Obesity is where the body mass index is greater than 30 and is a significant risk factor for development of heart disease, diabetes, heart disease, cardiovascular problems, stroke. And we'll speak about that later on, again, when hopefully we have a Q&A session regarding people's rights, people's duty of care, and restrictive practices. So for the record, a healthy diet, and you'll have to forgive me doing this because I'm a GP, but we all need to be following the recommended diet for all Australians, regardless of what we have or don't have, and it's a nutritional balance. And I won't go into detail other than say you can just Google Australian dietary guidelines, and you'll know exactly what it is, because it's been in every magazine and newspaper and any form of media for many years. And the aim is to stay within a healthy weight range. And I apologise to anybody that thinks I'm thinking of them at the moment, but it's a challenge for many of us to stay with good food. But with somebody who is not able to choose their own food that is best for them, we have a duty of care to make sure that they are. And there's this strain between current disability rights groups that are saying people with disability have a right to eat what they like, when they want. If they want to drink sugary drinks and eat lots of food that's bad for them, that's their right. But we have a duty of care to look after them and stop them from harming themselves. And there's somebody that was been watching tonight that is has taken this, it's got a legal background, has taken this on behalf of their cousin to a strong level. And I just want to read out a couple of things to you. A duty of care is a legal obligation that we all have to take reasonable steps to not cause foreseeable harm to another person or their property. That's a duty of care. Informed choice means that an individual has the right to make their own decisions, but it's based on three things: that they can't do that while they're under the influence of drugs or alcohol. They can't be coerced by a third party, and this is the most applicable point that they've pointed out, that they need to have the intellectual cognizance, the ability to understand the potential pros and cons of that decision. And that's why it's been ruled by a presiding VCAT member that for one guardianship order, that medical treatment needs to be given, including but not limited to any dietary restrictions to avoid serious harm to the person's health. The Katie White, the Assistant Director of Behaviour Support in Victoria, a quote from her: "The situation may require the need for staff to implement an environment restraint," that's the current politically correct term, "so that the person can be given healthy food choices rather than bad food choices." So as I said, I hope we'll be able to have some input from people watching this under a Q&A session at a later time. This is very important. It's not just about work. It's also vital for people to have good social and recreational activities. It's vital for people's both physical and mental health. There are lots of things that people with Fragile X can do and should do and can be involved in that are very enjoyable. A lot of people often say no, 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 but like anything, it's a matter of exposing them bit by bit and finding out what they enjoy doing. People often don't know what they enjoy until they've done it a few times. And it's important, and again, this can be done under the NDIS, to have a support person take someone to these activities on a regular basis. We see a lot of people with Fragile X enjoying these activities, developing an interest and growing their social skills as a result. So here's a young lady who was averbal. She was not able to speak with our previous speech therapist, and she couldn't speak, but we gave her something that she hadn't been able to do before, which was a picture exchange system that worked in the situations that she was being exposed to. But she was brought up by her grandparents because her parents were not able to look after her. He's one of a twin, and this young man was working at McDonald's for many years. He lives with his brother, who's a cleaner at night, and they both drive. There are a lot of skills that these guys are able to do. So I'll bring that to the end, and I'll hand back to Graham Hook, and thank you for the opportunity to present.
Thanks, Jonathan. That's a wonderful summary of, I think, what most of us would be experiencing with our adult Fragile X children. I'll throw out the first question to get things started. What treatments are on the horizon for adults with Fragile X syndrome?
What treatments are on the horizon? I'll answer. I won't answer it. I think what would be a more pertinent response to that would be that there are a lot of treatments that are currently available, both medication-wise and behaviour-wise. And although there's always a lot of interest in the latest research and the latest things to come out, it might be worthwhile remembering that there are an awful lot of things that have been around for a long time and which have shown to be extremely effective. So I don't want to be negative about new things coming out. Some new things are good, and there's a number of research projects that are always on the road, but they're research at the moment. And so to reiterate, I think there's a lot of things that are currently available and that have been shown to be excellent. So although we're always wanting to advance and move further, over the time that I've been involved with Fragile X now, which is getting on to 3 decades, the oldies and goodies seem pretty fine to me.
A question has come in. Is there a checklist that I can give GP to look for certain health things that you spoke about today, e.g. heart, etc.? Any tips for non-verbal young man, how to talk about pain? My son just says sore throat, but often it isn't a throat. but could be a sore tummy, etc.
So there's a few questions in there. I think Wendy emailed me some things before, and maybe they could be sent around. Someone's put in something that New South Wales is, the Council for Intellectual Disability New South Wales called a My Health folder. And perhaps Wendy could send that around. It's at cid.org.au, My Health Matters folder. And I thought that was pretty good because there's some tools in there for helping people communicate levels of pain, levels of anxiety. They would need some training to learn how to use those. So in terms of communication, there are a lot of those sorts of things that are available. And I guess you could just really Google, intellectual disability pain scales, or pain scales for people with intellectual disability. In terms of health checks, there's a very good formal assessment tool called a CHAP. It's a comprehensive health assessment program, which just about every residential unit institution will have in place, and that the GPs who go there will be using every year. And that's a full history taken from the person or the people that know them well, a physical examination, and a checklist of tests to be done. CHAP, C-H-A-P, developed by Nick Lennox in Queensland. Again, originally a GP from Melbourne. And it's GPs that seem to work with the intellectual disability, but not all GPs have an interest. It's a small number. So it's important to try and either upskill your own GP or find one that is aware of these things. The CHAP is a formalized assessment tool that gets recorded, but just about every GP knows how to take a history, do an examination, and do some basic tests. It's just called a preventive healthcare check. And I think everybody watching this tonight will hopefully have been to their GP and had this done every 1 to 2 years. And it shouldn't be any different for people with Fragile X. There's nothing they should miss out on. They still need cholesterol checks above the age of 40 or 45. They need a prostate specific antigen blood test. The girls need to have, if they've had intercourse, they need to have a cervical smear test. They need to have breast checks. They need to have mammographies starting from the age of 40 or 50. If there's a family history of bowel cancer, they need to have colonoscopies. They need to have dental checks, eye checks, and their ears looked at, their heart listened to every year. And if there's ever a problem, I was mentioning before, a change in behavior, the first thing to do is to see if there's illness. The most common change in behavior is where someone's got a sore tummy, usually constipation or a sore tooth. They talk about a sore throat. They know sore throat means pain. And so, there's body charts which can be used for people to point things out. And look, they're easy to miss. And I'm no different to anybody else. I've also picked up things later than normal, and it's very easy to miss things in people who are not able to tell you exactly what's going on. So standard routine check, there's nothing weird or strange about Fragile X. They have exactly the same health risks as everybody else. People in general with an intellectual disability, this is also work that Nick Lennox showed in Australia, they don't live as long in general because things get picked up later. That's a general rule across all people with intellectual disability, but there's nothing specific that shortens the life of somebody with Fragile X, providing they have the same preventive health care checks. In terms of documentation, I guess the purpose of documentation is for people to access it. And so writing it all down is great, as long as the next person who comes along is going to read it. And unfortunately with documentation now, and I think most people will be familiar with this, it's been overloaded a little bit, and people are spending all of their time documenting rather than getting to know the person. So what I usually try to get people to do with anybody with Fragile X, especially if there's difficulties with communication, is to have a communication book, a little hard copy exercise book, and the front cover ruled in half. On the left side, triggers, behavioural triggers, things that upset people, and on the right side, calming strategies, things that help people calm down. And everybody who works with that person or comes in contact with a person needs to know that list of triggers, what not to do, and things to calm down, to help the person calm down. And so that, to me, is maybe more important than widespread documentation. So to summarise, I think that it's standard preventive care, the same as for anybody. You can actually get lists of things from the RACGP, Royal Australian College of GPs website, what needs to be done, take it to the GP and say, here, I want you to do this with my son or daughter. If they're saying, well, we don't know what to do. Specifically with Fragile X, look, there are some things to look out for. I mentioned it's important to be aware of the connective tissue disorders. They can get a lot of problems with teeth, with their dentition, flat feet, because the feet lose their arch. Heart valve problems, the heart should be listened to, or if someone suddenly develops difficulty with exercise, that needs to be looked at. And we've spoken a little bit about being overweight tonight, and there are some general approaches to that. One is that it really can be a serious thing, and if someone is just a little bit overweight, so the BMI is 26 rather than between 20 and 25, okay. Once it gets over 30, that's a serious risk factor for heart disease and stroke. And development of diabetes, which then really increases the risk of these things. And so without making anyone feel uncomfortable, there's some really simple, not quick fixes, but simple approaches. The first is to do exactly what your dietitian did, which is, where possible, avoid, there's no reason or need to have sugary drinks. They can be the same drinks. You can have Coke Zero or the diabetic drinks. They can still have soft drinks with no sugar in them. Instead of Mars bars, to look for some other food that the person likes that they can have. But the general approach to being overweight now, the best approach, and this is especially for males with central obesity, so big tummies, is a low carb diet. And again, you can just Google low carb diet, but simply put, it means really reducing bread, potato, rice, and pasta. So reducing the carbs and having more protein, meat, fish, egg, soy, and more fat as a result. There's carbohydrates, proteins, and fat. If you reduce your carbs, you've got to have more protein and fat. If the cholesterol starts going way up, then you can use medications for that. But the only way to get weight down, or the best way, I should say, to get weight down is actually dropping the carbs significantly. So there are a whole lot of clever ways that can be done, and the person can be involved in that by choosing and being allowed to choose their own foods. And that's a behavioural approach that can take 2 or 3 weeks to change, but once the person has changed, they'll be locked in. And the good thing about Fragile X is that once somebody is in the routine, that's what they're going to do. They're not going to change from it. So if you can implement that, that's how it's going to be.
Jonathan, thank you. I personally found that very interesting, and I've learned a lot from you in the past, and also particularly through the Fragile X Association. The adult side is fairly new. When James was a teenager, most of the information was still about early diagnosis. So it's good that we've been able to talk about this, share our experiences,